If you look at the national uh, consensus report 2018 on pregnancy in diabetes in pregnancy, uh, it has thrown up some of the questions because you look at the update, it says that over the last 5 years, nothing has changed. As far as dealing with the risk of pregnancy is concerned, we could not move an inch. So that is a huge task or a huge question. So in that background, I have framed a question. For the kind introduction and my regards to Magna Code and the organizer, Dr. Anantharaman. Next 15 minutes, I would discuss relevant sections of the allotted topic. This is the overview of my discussion. If you look at the national consensus report 2018 on pregnancy in diabetes in pregnancy, it has thrown up some of the questions because you look at the update, it says that over the last 5 years, nothing has changed. As far as dealing with the risk of pregnancy is concerned, we could not move an inch. So that is a huge task or a huge question. So in that background, I have framed a question, and through my talk, I would try and answer this question. That is, could CGM help bring about the change suggested in order to improve outcomes in pregnancy? I think all the time that I'm going to spend in the next 15 minutes or so, I'm going to try and sort out and try and get an answer for this question. But if you scourge through the literature, we have ample evidence that if you put in effort and bring sugar in the normal range in pregnancy, obviously it will be hugely rewarded, not only to the mother, but also to the neonate. And often what we miss out completely in our dealings when we manage pregnancy is the glucose variability. If you, let me just introduce J index. Actually, it is a measure of glucose that incorporates mean and standard deviation of glucose. So in fact, J index comprehensively capture every dynamics of glucose levels in a given lady. So naturally, you look at the illustrations on your right hand side, you see that the upper graph, the J index is lesser, and in the lower graph, the J index is rather high. So in the upper graph, the mean glucose levels are low, and in the lower graph, the mean glucose levels are high. So does that make any sense? Yes, indeed, because higher the J index, higher would be the risk of large for gestational age babies, higher would be the risk of asymmetrical fetal growth. And also, if you analyze carefully, this HbA1c is not an accurate predictor of prevailing glucose levels. And HbA1c has its own fallacies when we apply it in pregnancy. I'm not going into the details, but we all know that. But there are calls from different quarters to replace or substitute HbA1c with different CGM metrics. Like, you have time in range, you can also calculate the mean glucose levels, because it makes sense. Because the average or the mean glucose levels derived from CGM metrics is far more an accurate representation in a given case than the average glucose levels which you get from HbA1c. Also, if you take the time in range into consideration, time in range often can give you valuable inputs which helps you to minimize the risk of hyperglycemias, hypoglycemias, and glucose variability. So essentially, if you use CGMs, it opens up a new vista and give you more inputs for better management of glycemia in pregnancy complicated by diabetes mellitus. This is international consensus recommendations quite clear on the use and targets of CGM during pregnancy, and in fact, the consensus panel concluded that using the time in range as a metric in addition to HbA1c during pregnancy would give you more actionable input where you can take better actions in comparison to the situation where you are using only the standard of care. So what is the time in range in pregnancy? It is 64 to 140 milligrams. I think that is the glucose range that you should be targeting. And in type 1 diabetes mellitus, the time in range should be around 70%. In type 2 and GDM, you should try and keep the time in range more than 90%. And either case, you should try and keep the hypo or time below range less than 4%. I think this is the recommendation. So to quantify whether it is in time in range, time outside range, time above range, below range, can you do it with SMPG and HbA1c? No. You need to have a mechanism wherein you can quantify the above range, below range, in range, etc. For that, I think we have right now, only have CGM as tool, a useful tool to quantify these parameters. This is the compendium of data published where CGM is used in type 1 diabetes mellitus. Most of these cases, or in these studies, CGM was used as an adjunct to the standard of care, and put together these available data, in fact, press for a compelling reason for us to use CGM as an aid apart from standards of care because of the additional benefits that we are going to get. For example, if you look at Murphy and et al. Trial where 71 women were studied, most of them were having type 1 diabetes mellitus. And you see that with the usage of CGM, the mean HbA1c could be reduced significantly in the second half of the pregnancy. Also, there is significant risk reduction in terms of macrosomia. But many trials, the data as such is heterogeneous because some trials did not reproduce results in the same line. But the magnum opus trial in this segment is Concept 2017, which was a multi-centric randomized blinded trial, 12 months, examined the utility or explored the possibilities of CGM in maternal glucose control, obstetrics and neonatal outcomes. There were 325 women participated in this study. And what were the results? There was a significant, even though it was small, reduction in HbA1c, mean HbA1c to the tune of 0.2%. And the icing in the cake is, look at the improvement in time in range from 68% against 61%. That has taken place without increasing the time below range or without increasing the risk of severe hypoglycemic episodes. So the study concluded that every 5% increase in time in range, there is significant improvement in the composite of neonatal outcomes. So even 5% improvement in time in range does matter. There is also significant reduction in the risk of large for gestational age babies, significant risk reduction in neonatal hypoglycemias. There is 1 day lesser need for hospitalization post-delivery. There is reduction in risk of neonatal intensive care unit admissions. But what about economy? Because I think use of these gadgets will jack up the cost of management of pregnancy. But here again, there is a financial model proposed by the Concept Collegium, and it has predicted that indeed CGM usage can save cost because you look at the fraction of expenditure put under different heads. You see there is a huge difference in the column of the gray columns because that gray column represents the need for NICU admission. So by using CGM, according to the financial model proposed by the collaborators, there is significant reduction in the need for NICU admissions. Henceforth, you can save money in that regard. That is the compendium of data of usage of CGM in gestational diabetes mellitus. Again, let me just give you some details of the Yu et al. Trial, which was conducted in 345 women with gestational diabetes. Again, here the CGM use was blinded, and the study came out with some wonderful results. There is maternal benefit in terms of reducing the risk of preeclampsia, fetal benefits ranging from reduction in small for gestational age babies, large for gestational age babies, reduction in obstetric trauma, reduction in small for gestational age babies, reduction in neonatal hypoglycemia, hyperbilirubinemia, etc., etc. So huge benefits. But here again, the data is heterogeneous. The Close-in-Heel Wei et al. Had published his data, which did not get results in the same line. In fact, it was ambiguous. So you can't make tall claims if you study through this available data, because data is quite kind of heterogeneous. This is Swedish data, again suggesting that with where women who have used CGM was pitted against women who received only standard of care, and they found that with increasing gestational age, there is a clear-cut improvement in glycemic control by all means, and also glycemic control in terms of mean glucose levels and time above range and time below range were closely associated with outcomes like large for gestational age babies or composite of neonatal outcomes. So indeed, glucose control is hugely rewarding if you can quantify these parameters and act accordingly. Now, this is additional data to suggest that use of CGM can bring down the mean HbA1c levels in the later half of pregnancy and also reduce the risk of macrosomia. Now, the second part of my talk, that is the practical usage. Let me introduce you to this real life case I have managed 5 years ago. I was in the team. So this is a 29-year-old IT professional having type 1 diabetes for 11 years. She was managing all this while her diabetes with multiple injections, subcutaneous injections and home glucose readings. And she was reported at 12 weeks of gestation because she had poor obstetric history, because last 2 of her pregnancies ended up in abortions. So she was admitted for introduction of pump therapy and also to put her on real-time CGM and also to give her assistance and support. She was weighing 71 kilos and her HbA1c at the time of reporting was 7.1%. And this was her baseline CGM. Look at her baseline CGM. You see her sugar all over the place. You don't want to see this happening in a pregnant woman, isn't it? So you see, this is if you look at the J index, it is quite high because the glucose variability is quite high. The sugar levels are hopping all over the place. So we put our heads together, and she underwent counseling education. She was introduced to carbohydrate counting exchange, and in addition to SMPG, she was put on real-time glucose, continuous glucose monitoring, and the pump, of course, was introduced. She was proactively managed. As far as her basal insulin requirement is concerned, bolus was based on her carbohydrate counting. Correction bolus was given on as and when needed basis. She received psychosocial support. Her spouse and her parents received counseling. She was kept in for 3 weeks. So 3 weeks is the intervention that we have applied, but we did everything what is possible, and look at the results. So this is the pre-intervention CGMS, and that is the post-intervention CGMS. See how much, to what extent could you influence her glucose dynamics for the betterment of the mother and pregnancy. You know why? Because you have additional data at your disposal. You have more information, actionable information. That is what is more important. So the more actionable information you have, the more you act. So the better would be the outcome. So post-intervention, so she delivered at 38 weeks, birth weight was 3.6, no untoward neonatal incidences, and she was discharged day 4. So the highlights of this case is CGM enables actions to adjust for glucose in real time throughout pregnancy. And improvement in neonatal outcome detects more maternal hypos and hyperglycemias and fluctuations. And the CGM identifies nocturnal hypoglycemia and postprandial hypoglycemias. To conclude, ladies and gentlemen, CGM provides a powerful new tool that promises to help us achieve goals of improved outcomes by various ways, because CGM, as I said, derived mean glucose levels may be more accurate than HbA1c. And time in range is hugely, I think the potentials are still to be explored. We need more mechanisms to utilize CGMs and its scope and take the treatment to altogether different planes, and improvement in patient and provider's experience, that is more important. CGM provides far more data and therefore more opportunities to improve glucose control, that is also there. Enhanced ability to deliver care remotely, because now most of the manufacturers have come out with their own software, so CGM can be put in remote places where access to healthcare is minimal, and the data can be retrieved and it can be sent to a central software processor where it is analyzed, and the report can be delivered back to the healthcare provider in no time. I think that is one area which I think we need to explore more, and more changes are needed to optimize outcome. That is because even now 50% of pregnancies complicated by type 1 diabetes ended up in large for gestational age babies. So we need more work, we need more action. And prognostic tool is, of course, because CGM can risk stratify pregnancies by different mechanisms, and also can pinpoint pregnancies where intensive glucose control would be the most beneficial, like the case which I was referring to. Thank you so much.